So let me start today by introducing the first speaker, Dr. Richard Barr. So Dr. Barr is from Northeastern Ohio Medical University, practices at Southwoods Imaging, and I know Dr. Barr for a long time, so I probably don't really need to read off of the paper too much, but I'll give you some of his credentials. He's the editor-in-chief of the Journal of Ultrasound and Medicine. He's very, very involved in contrast imaging for years. In fact, he is the treasurer of the ICUS Contrast Society, but he's been working with contrast for years and years. He's part of the KIBA group, who's working on attenuation imaging, another one of the tools in the toolbox for liver imaging. He's been doing elastography, breast imaging, he's involved in urology, so many projects over the past 20 years. 200 peer-reviewed papers, book chapters, several books, 600 scientific and educational presentations, and invited lectures worldwide. And I think more interesting than maybe all that is he really enjoys downhill skiing. And he's a great skier, and he loves to go to Whistler and Snowbird in Utah. So he's here. He's got the right weather conditions, although there's no hills. So unfortunately, he's going to have to find a hill somewhere. And he's going to be presenting this evening. His lecture is entitled Decoding Liver Health with Multi-Parametric Ultrasound. So please welcome Dr. Barr.
Thanks, Dan. And unfortunately, we have the same problem in Ohio. We get snow, but no hills. Makes it hard to ski. So I want to thank Canon for inviting me. They've got some really incredibly new software and techniques for evaluating liver. I do have so many disclosures that I don't have any conflicts of interest. And also this information presented represents the clinically experienced and professional views of me and not Canon, and actual results may vary based on the use and the clinical environment. Products and claims that are being presented may not be available in all regulatory regions. Please consult your local Canon representative. So I think you all know chronic liver disease is really a worldwide problem. It's estimated that probably 25% of the world population has some element of fatty liver disease, and we now have drugs for hepatitis B and C, which are making those less prominent, and fatty liver disease is really becoming our biggest issue, and we'll talk about that a lot today, and my partner in crime, Dr. Ferrioli, will give you a nice summary of what we know to date. And again, what do we want to do? We want to be able to stage these people because it's really important to know prognosis, surveillance. We now know if we treat the underlying condition that we can see reversal of fibrosis and surely of fat. So again, we need a technique that we can do over time. And not, biopsy obviously is not something that we're going to get patients to volunteer to get biopsies every 6 months. MR is a little expensive, so really ultrasound is going to be a very key role in evaluating these chronic liver diseases as we have these treatments and we can see reversals of the disease. And again, we know that this process, so when I was in medical school many decades ago, we were taught fibrosis only progresses and that's it. Well, we now know, especially now that if you have a TV, you know we have drugs for hepatitis C. They work really, really well. And we see over the course of years, regression of the fibrosis. So these drugs work really, really well. And I think the drug initially was very expensive, but it's now very inexpensive and almost worldwide. Everyone that has hepatitis C is being treated. So we're really expecting the disease to drop. We've got drugs that suppress hepatitis B, and fatty liver disease is now the leading cause of liver transplant in North America. So that's really our thing. And again, you know, I usually have a whole day to do this, so we're going to try to do this in 15 minutes, so we're going to pick up highlights. One thing I think is really important to realize is that liver biopsy is not a very good reference standard. When we look at studies of pathology reviewing the same slide, they don't do a great job. And there are papers that show that one pathologist may call something metavar 1, a different pathologist may call the same slide metavar 3. So they sometimes are off by 2 metavar scores. So if we try to analyze our results compared to liver biopsy, it's not a really good reference standard, and we'll talk about how we overcome that. Now, the Biveno conference several years ago decided that Medivar scores, again, didn't really correlate with what we do, and they suggested using the term compensated advanced chronic liver disease. It really is F3 and F4, and these are the people that are at high risk for chronic liver disease and all the complications, development of HCC, portal hypertension, and liver dysfunction. So again, we're moving towards this, and almost all the guidelines are now using compensated advanced chronic liver disease. Now, briefly to go over what do we need if we're going to look at chronic liver disease. There are three things that we really would like to know that hopefully we can do with ultrasound. One is liver fibrosis. We need fat quantification, and we need liver inflammation. So we have shear wave elastography that we can look at fibrosis, liver fat quantification. Dr. Ferrioli is going to give us a talk on where we're at with attenuation imaging. There are a few other methods that we'll talk about briefly, and liver inflammation is the one thing we've kind of missed. And we'll talk a little bit that Canon's dispersion slope may provide us some information on the degree of inflammation, which would be very critical for us making the distinction between NASH and non-alcoholic fatty liver disease. I just briefly want to review shear wave elastography. The SRU guidelines, I think, have become the standard for the world, really, in evaluating how to do a appropriate shear wave elastography. And if you look at the two papers, one published in 2015 and one published in 2020, they go over a lot. And the WFM guidelines, the World Federation of Ultrasound and Medicine guidelines, that were published in 2018, have a little bit more information. And within the next 6 months, hopefully, we were going to have another guideline that comes out with the World Federation of Ultrasound and Medicine that will bring us up to date on new findings. And the WFM guidelines will adopt the SRU cutoff values. And I really want to thank Canon. They're one of the systems that we have proof that the cutoff values work on their system. So that's really important. And we're hoping that all the other ultrasound vendors will be able to get to the point where their machines all work with the SRU cutoff values. This is just a quick slide to just remember what we do with shear wave elastography. A is our RF pulse or push pulse. You'll notice that there's an area that's red. That's where the most energy is deposed. That's where the best shear waves are. And that usually is around 4 to 4.5 centimeters from the transducer. So we recommend that you try your best to do your measurements in that area because that's where the best shear waves are. B are the tracking pulses. Again, the RF pulse generates a shear wave, but it's actually our B mode that tracks the shear waves and calculates the shear wave speed. So if you have a bad B mode image with any artifacts, with any shadowing, you're going to get an inaccurate shear wave elastography. C is showing you what we see in the machine, that each of those lines correspond. So the blue line is closest to the RF pulse. You'll notice it occurs faster and it has a higher attenuation. As we move away, it takes a little bit longer. The bottom slope is time. And we see that the shear waves are also attenuated. And if we plot the travel distance over the time, then we get a straight line, and that's a shear wave speed. And what we also recommend is, again, 3 parallel lines. Why? If you don't have a bright white liver capsule, you are angling the transducer. And this creates problems because the beams are bending, and also you're not getting the most energy out of your RF pulse. So we have the transducer, the liver capsule, which should again be a bright white line and parallel, and the top of the box. Either it be point shear wave or 2D shear wave. And this is really, really important, and I don't have time to go over this, but basically if you have any angulation here, it's just like using the wrong angle when you're doing Doppler. So you're going to get wrong results. This slide summarizes everything we did with the SRU in 2015. We have pre-test probability and post-test probability. We have cutoff values, but they vary on the population. So you have to take in the information. Our values are one of a big piece of information that we have to put together to understand this. So what I like to say is if you have a cirrhosis clinic, you don't want to miss anyone. So you may want to lower the cutoff values we give you so you don't miss anyone. By the same token, if you're doing mass screenings, you don't want to overdiagnose, so you may want to raise the cutoff value. So our cutoff values that we're going to give you are general rules for a general population, but depending on your population, you may want to move it. And also we have age, gender, ethnicity, and lab tests affect our results, everything in the funnel and many, many other diseases, anything that causes inflammation in the liver, including fat deposition, is going to give us fibrosis and on to cirrhosis. We've got patient factors, obesity, ascites, medications, and fasting that will affect our results. We have comorbidities, acute on chronic disease, and vascular congestion. It's important to remember we never measure fibrosis, we measure stiffness. And stiffness is a combination of fibrosis, inflammation, and congestion. So if you ever have a patient that has more inflammation, someone that's on alcohol, someone with acute hepatitis, the values are reflecting the inflammation, not so much fibrosis. The same thing with somebody with right heart failure. Also, we have MR and we have ultrasound, and within ultrasound, we have a couple different types of ultrasound. So all these things affect, and this is a very, very difficult exam, and I don't have time to go over everything, but I do recommend if you're doing this, you read the guidelines. You need to do all those pieces that we talk about to get a good value. So this is again from the SRU consensus in 2015, and what we did is we looked at likelihood ratios. So for a given shear wave speed, what was the probability of a certain Medivar score? So if we look at 1.3 meters per second in this large study that was done quite a while ago, you have a 2% chance of being F0, a 10% chance of being F4, a 20% chance of being F3, and a 35% chance of being F2 and F1. So what you'll notice is we do really well in no or mild fibrosis, and we do really well in compensated advanced chronic liver disease. But between those two, we really have a very difficult time sorting out exactly where we are. So we gave cutoff values, and at that time they were vendor specific, as to a low value below which you had no or mild fibrosis, and a high cutoff value above which you had a very high probability of compensated advanced chronic liver disease. And between those, you had some fibrosis, and you needed to be followed. Now, this data is true for transient elastography, and it's also true for MRE. So all these things that I'm telling you, almost all of them affect both transient elastography and MRE, although they tend to not tell you that. Now, another interesting fact, and again, because we don't have a lot of time to go over a lot of things, but one thing that's really important, if you have patients that have hepatitis C and they're treated, you should do a liver stiffness value before treatment, because if they have compensated advanced chronic liver disease, let's say maybe above 10 kPa, that they are at risk for development of hepatocellular carcinoma, varices, and all the other complications, even if the drug works very well. So once you treat these patients, their values will drop pretty dramatically, which we believe is the resolution of the inflammation. So you can't use the cutoff values anymore because they drop dramatically. They can drop. We have patients that come in with 12 kPa. After treatment, they're 6 kPa in 6 months. Their fibrosis hasn't changed. It's all resolution of the inflammation probably. So we can do that. So we recommend that you now say, okay, their new value is 6 kPa. That's their baseline, and we're just going to follow that value. So the change over time is sometimes more important than actually looking at the cutoff values. And this is true also for pediatric patients that may have Fontan surgery, because again, their values are a combination of congestion and fibrosis. So what we want you to do is do a value as a baseline when their cardiac function is tuned up as best as possible. That's their number. And then you can tell if they're getting worse or better based on the change over time. So our SRU guidelines are the rule of 4, starting at 5. So equal to or less than 5 kPa, high probability of being normal. Between 5 and 9 kPa, in the absence of other known clinical signs, rules out compensated advanced chronic liver disease. If there are known clinical signs, may need further tests for confirmation. between 9 and 13, suggestive of compensated advanced chronic liver disease, but need further tests for confirmation. Above 13 kPa rules in compensated advanced chronic liver disease, and greater than 17 kPa is suggestive of clinically significant portal hypertension, but not diagnostic. We know these values work really well for fatty liver disease and the viral hepatitis. We don't know about all the other etiologies. We don't have enough data, but we think that these, and the lack of other information, are what we can be used. So if we look back at that table, we now have redesigned things. We kept 5 kPa, below which you have no or mild fibrosis. We moved the high cutoff value from 15 to 13 because I think we now realize that people that had F3 disease actually are at risk for all the complications of chronic liver disease, so we wanted to not miss them. So we moved that down, and then we split the difference between the 5 and 13 at 9. And if you look at this table, you'll notice between 5 and 9, the vast majority of those people have what we were calling F1 and F2 disease, mild or moderate fibrosis. But when we get above 9 kPa, notice that we are now getting a lot more people that have severe fibrosis or cirrhosis. So again, you have to take not only this information, but all their other clinical information, put them together to decide where the patient's at. And one of the tests, the FIB4 test, blood test, I think is in the literature now coming up to be one way for this middle group to decide if you want to go no versus compensated advanced chronic liver disease. The other thing that it's, I think, important for most of us is that when we look for fatty liver disease, what most papers say is above 9 kPa, there's a high probability of having NASH. We can't make the diagnosis of NASH, but above 9 kPa, we're very suggestive of NASH. And some paper even suggest low as 7 kPa may be associated with NASH. So I like to say above 9 kPa, I dictate that NASH is highly probable. Between 7 and 9, I say NASH should be considered. And again, I'm hoping with more research and more papers, we'll be able to define that a little bit better. And we may need to take in some other factors to do that. And again, I mentioned this again, it's really important that you realize when people are treated, oftentimes the treatment is not resolving the fibrosis, it's resolving the inflammation. Then our cutoff values don't work. You have to go after they're treated, get their own baseline, they become their own reference standard, and then you look at the delta change over time, and that's really helpful. And again, this is useful for almost anything that we do. In fact, even congestive heart failure. So theoretically, we could go do liver stiffness values every day in the cardiac intensive care unit, and you can tell if the treatment is working because fibrosis is not going to change daily, but the treatment of their congestive heart failure will. Again, Dr. Ferrioli is going to kind of go over fat quantification, but I just want to bring up that we have the hepatorenal index. It's been around for almost as long as I have been. Attenuation coefficient, backscatter coefficient, and speed of sound, which the PICAS group, is looking at all of these. Most vendors now have attenuation coefficient. I think it's pretty useful. And again, Dr. Ferrioli will give you an update on all of that. I just want to point out that ultrasound is really the modality of choice for looking at chronic liver disease because it's widely available, it's inexpensive, and you can notice we have a healthy liver, go to NAFLD, to NASH, fibrosis, cirrhosis, and again, we now have fat quantification to make the diagnosis of NAFLD. We've got point shear wave 2D and maybe dispersion slope that's going to help us decide about NASH. Again, shear wave is going to help us with fibrosis, cirrhosis, and then obviously, we've got ultrasound contrast that we can look at focal liver lesions. Now, just briefly, liver biopsy has been the gold standard. But again, we can see changes dramatically. If somebody fasts, their liver fat can change in a month. So we can't biopsy everyone monthly to see what's going on. So it's really not a very good gold standard. MR-PDFF measures something completely different than liver biopsy, but it's been well accepted that we can come up with values, and I think it's now the gold standard, but again, not widely available and not cheap, and I doubt that MR insurance companies are going to let us do multiple MRs a year. So ultrasound is really the method of choice, non-invasive, low risk, widespread access, real time, low cost, and it's great for screening. And there's no reason why some of these can't be put on lower end systems so we could do mass screenings even in underdeveloped countries. And again, I don't want to go over this in detail, but this is basically what we see, and hopefully this pointer works. So we're putting in this big box, but we put in this box, which is measuring the attenuation, and we get a value out, and we also get a score that tells us about the quality of the exam, and I think Dr. Ferrioli is going to go over that in a lot more detail. But inflammation is the bugaboo that we've had for a long time. We don't know how to do this. So it is a confounding factor in liver fibrosis, so we do see elevation of the shear wave speeds with this. It's indicative of acute disease. And again, ideally, we would like to do this. So the question is, can dispersion slope, which is measuring the shear wave speed at different ultrasonography pulse frequencies, is that going to be helpful? And again, what we see is if we have a perfect elastic tissue, that we should have the shear wave speed should not change with the frequency, but obviously the liver is viscoelastic and it changes again with the degree of fat. So again, we get this slope, which is the meters per second per kilohertz, and it's hopefully related to liver viscosity and maybe some other factors. We're still trying to work that out. And the question is this going to be some way that we can distinguish NAFLD from NASH? And again, here you can see we're doing these measurements and we get not only the liver stiffness, but we get a dispersion slope that tells us how things change over time. We have finished an iLEAD study, which is a multi-center international trial with these people as investigators. Dr. Shigemoto will, on Thursday, give the results. I'm just going to briefly go over that. We have some older papers, but again, we're going to have hopefully a new submission by the end of this year or beginning that shows that there is a reasonable relationship to shear wave slope with inflammation in addition to other things. And again, this is his unpublished data that he'll be showing on Thursday. But you'll notice that the steatosis grade goes up based on attenuation coefficient. Very good correlation between attenuation coefficient and steatosis grade. The dispersion slope seems to correlate with lobular inflammation and grade, and our shear wave speed does correlate with fibrosis. And again, we have several papers now that show that using the Canon system, the SRU guidelines work perfectly, and we're very happy that they did that, and we're hoping all the other vendors will move to do that. And again, I'm just going to give you some, here's an example. Again, we're here when we're doing the shear wave speed. It also calculates the dispersion slope. So we get with one push, we get both of that information. If you want, you can also do fat with one push. We prefer to do it with two pushes, but then you get this beautiful chart report page that shows, okay, we did 10 measurements, we did 5 attenuation measurements. It gives us the median shear wave speed, it gives us the elasticity in kilopascals, it gives us a dispersion number, and it also gives us an 18 number. And you can see with these nice sliders that it kind of gives you a visual of where we're at. So this is, I think, really helpful. And then maybe we're going to have to add a couple more of these once we maybe have AI combine all this data and give us maybe a score of chronic liver disease. So that hopefully is coming. We published this paper a while ago with the Canon system. So we did a study and we showed that we can do a complete analysis in 3 minutes. So we can do dispersion slope, shear wave speed, and attenuation imaging all at the same time. And again, this paper was published, I don't even remember where, that we did this in 3 minutes over a large number. It was over 100 patients. So, and it didn't seem to matter. Even our newer techs and experienced techs actually were able to do this quite quickly. I just want to end with this case because I think it's really important for us to understand how ultrasound can affect this. So we have the 64-year-old woman. She comes in with mild elevations of ALT. She was Spanish. She was really mad. She says, I don't know why my doctor sent me here. There's nothing wrong with me. So we do her in March of 2020. She's got an extremely fatty liver, and her liver stiffness is 35 kPa. So her doctor tells her, you've got cirrhosis. So she was really panicked. And he said, you got a really fatty liver. She comes back 7 months later. Now she has only minimal fatty infiltration liver, and now down to 7.7 kPa. So what happened? And we did a biopsy. It confirms that our results are right. She lost 70 pounds in 7 months, and just losing that weight completely resolved her fatty liver disease and brought everything down. So my concern is, or my idea is, that maybe we don't need a biopsy to diagnose NASH. What happened? In 7 months, the fibrosis didn't change, right? This change, dramatic change in the kPa, has to be resolution of inflammation. So maybe this patient did have NASH, and now with her modification of habits, that she's corrected that. So again, I think that we need some more research to do this, but I think doing ultrasound and looking at the change over time and how these people react to treatment may be an easy way to get away from doing liver biopsies and still making a diagnosis. So again, we didn't have time to go over the strict protocol. It's very, very strict. You have to follow everything to do that. And again, I recommend you look at the SRU guidelines from 2020. There is now excellent treatments for hepatitis B and C, so we're not seeing these patients getting to the level of compensated advanced chronic liver disease because almost everybody's being treated. NASH is really our big problem now, and hopefully, I think ultrasound now will be able to answer all these questions. Dispersion slope is a promising method of evaluating the degree of inflammation. We still have some concerns, and we don't completely understand it, but it looks like that's something that in the future we'll be able to use, and maybe combining AI with all the other factors, we'll be able to come up with a NASH or MASH score, whatever you want. And again, we can really quantify fat really well, which Dr. Ferrioli will talk about. And again, I think just looking at the change over time is really good for us to decide if a patient's getting better or worse.